Today I'll be chatting with Dr. Zoe McLaren about COVID-19 testing. Dr. McLaren strongly believes that robust testing programs are a vital tool in the fight against COVID-19, and that they have yet to realize their full potential. As she explains, even imperfect tests can be incredibly valuable as part of a broader testing program. Our conversation gets into the nuts and bolts of different diagnostic and screening tests, how they're being used, and how they could be better deployed for maximum impact. We also discuss how COVID-19 testing data can help each of us to understand the COVID-19 situation in our area and elsewhere. As someone who spends far too much time looking at my regional COVID dashboard, this was a definite highlight. We close with a discussion of what testing might look like as part of the next 6 to 12 months now that vaccines are rolling out and new testing technologies are coming on board. Dr. Zoe McLaren holds a Ph.D. in Public Policy and Economics from the University of Michigan and is currently an associate professor in the School of Public Policy at the University of Maryland, Baltimore County. She has worked extensively in other infectious diseases, including HIV and TB, and is now focused heavily on COVID-19. She's written and spoken about COVID-19 testing policies and is currently developing methods to estimate COVID-19 prevalence. Let's dig in. Welcome to Get Real Health. I'm your host, Dr. Chana Davis. This show cuts through the noise to give you science-based insights from real experts so that you can make smart, healthy choices. Dr. Zoe McLaren, welcome to the show. Thank you so much for being here.
It's a pleasure to be here, Chana.
As you know, I discovered you through Bill Nye the Science Guy. It was actually the first episode I listened to was yours, and I'm really glad I did because I think you do a really great job of providing a public health and policy perspective that's different than when we normally spend time thinking about just our individual choices and decisions. So I'm looking forward to digging more into how the same data serves a different purpose for individuals and at a policy level.
Exactly.
Yeah. I also really enjoyed your article in The Conversation recently, which I hope we can touch on a little bit. I think you entitled it "Stop Blaming Testing for the Rising COVID Rates," something along those lines.
It's basically that the soaring COVID cases in the U.S. are not due to testing, but they really do represent increase in actual cases.
I think it's actually really interesting how all of us, definitely including myself, are becoming a little bit more educated about epidemiology, but it can be a bit dangerous when we get this concept of, tests that case rates are related to testing rates, and then we over-apply it when perhaps not appropriately.
Exactly. I think everybody's learned an awful lot about epidemiology and public health over the past few months for good reason. But then we also need to be aware of our limitations so that what we learn outside of, academic training has limitations. So we need to be careful that we're not overconfident about that.
So to set kind of the groundwork for the rest of our conversation, I think we need to get some terminology straight and just sort of go through the nuts and bolts of the main types of testing for COVID that are out there without gory details, just so we have the term straight and we can. And I think you and I agree that we'll focus our conversation on the diagnostic side, but just you should probably differentiate from the antibody testing up front.
Exactly. And so there's a couple of different ways that we differentiate tests. So in terms of diagnostic tests, we also differentiate between diagnostic and screening approaches to testing. So the way to think about it is generally what are the different types of test technologies? And then we can think about how we actually use them in terms of testing programs. And so we first need to differentiate between tests of current infection and tests of current or past infection or exposure. So there are antibody tests that test whether somebody has been exposed to the virus in the past. And we want to leave those aside for this conversation and focus specifically on tests of current infection. And those tests will tell us whether somebody is currently infected with the virus and also give us some idea about whether they might be contagious, which is one of the key things we need to know when we think about designing public health policy. And so the type of test that most people are most familiar with is the PCR test, polymerase chain reaction. And the idea with that test is, for the most part, requires a lab. And what it does is it takes the test sample, so often a nasopharyngeal swab, so the swab that goes right into the very back of the nose, or it could use a swab that just uses a sample from the nostril. And basically, It's put into a machine, and the machine replicates if there's any viral particles in there, it replicates those particles. And so basically it's a way to tell if there are any viral particles in the sample. And it's very, very sensitive to small amounts of virus particles because of the replication process. It kind of amplifies the virus RNA. So we can detect very low levels of the virus. And then we have antigen testing. So this is what is often known as a rapid test. There are rapid PCR tests, but this is a kind of rapid antigen testing. And so the idea with the antigen test is that it doesn't replicate virus RNA. It just works with kind of the virus particles, virus proteins that are in the sample. And what it does is it's usually a paper strip that is embedded with antibodies. And what those antibodies do is they attach to viral particles in the sample. So again, we use a nasopharyngeal swab or a nostril swab, or potentially using saliva, depending on the different types of tests. And basically, those antibodies will bind to the virus proteins and then also bind to color indicators. And so when we read the antigen test, we can see usually a line or two lines that indicate that it's a positive result. So one of the lines is a control line to make sure that the test is working properly, and another line that shows whether there were virus particles in the sample. Mm-hmm. And that antigen testing is very similar to what the technology, almost identical to the technology used in pregnancy tests. And so it's a rapid test, but it is less sensitive in certain cases because it doesn't amplify the virus particles. It just works with the sample itself. And so it's not going to be able to detect very low levels of the virus quite as easily. Mm-hmm. But that doesn't mean it means that it has some limitations, but we can use it in certain types of public health screening programs that enable us to use the antigen test to its full potential.
Yeah, so I think just to summarize those two, the PCR-based test has the advantage of maybe a little bit higher sensitivity because it can detect a lower copy number, whereas the antigen test is using a protein. It's not quite as sensitive, but you can generally do it faster because it doesn't require a lab. You can do it on site, and you can get a result very quickly.
Exactly. And the way that I think about the antigen testing, the rapid tests, is that it is able to do the test rapidly, and it sacrifices a little bit in terms of sensitivity, but it actually sacrifices the sensitivity where it matters least. So it is still very sensitive for patients who are highly contagious, and less sensitive for patients who may be beyond the contagious period.
Yeah, my understanding is that it can take maybe 3 to 4 days after exposure to have a PCR positive test. Is that your understanding as well in general? I mean, a different test, I suppose different labs run different assays, and so they're going to vary sensitivity from lab to lab. But I was actually looking this up for, of course, personal situations, and wondering how many days after exposure can you actually really trust a PCR test versus an antigen test, because your viral load goes up by the day.
Exactly. And so the idea about kind of when is if we think we might be exposed, how long should we wait until we get a test to kind of get the best chance of getting kind of the actual accurate result. And so part of that depends on the virus incubation period, which varies from person to person in different cases. And so the virus incubation period could be anywhere from kind of 3 days to about 10 or 11 days. And that incubation period is after you've been exposed, but the virus hasn't kind of yet started to replicate. And so you're not contagious yet. Your tests are not necessarily positive, but you're still infected with the virus, and your contagiousness and your viral load will increase kind of once the incubation period's over. So at the end of the incubation period, the virus starts to replicate, it kind of comes alive. And so it is going to kind of shoot your viral load up quite steeply. So it's going to rise very quickly. And then it will kind of stay high during the period of peak contagiousness, and then it will decline after that. And we have a little bit of information about the pattern, kind of if the kind of several days afterwards what the pattern of viral load is, but we don't have really good data on that at this point. But basically there's kind of a peak contagious period early in infection, and then viral load drops down and contagiousness drops down as well. So at the end of the incubation period, when the virus starts to replicate, there's a very, very steep increase in the kind of amount of virus in the body. And so early in that period when the virus is still pretty low, PCR tests are going to be more sensitive than these antigen tests. But that window where early, kind of before the peak, where PCR tests are more sensitive than antigen tests, is actually a very short window of time. And then at some point during the peak, both antigen tests and PCR tests are able to detect infection. And that's when people are most highly contagious. Yeah. After the peak, the viral load drops down. It's going to be past the point where an antigen test might not pick up the viral load in the body. The person might be less infectious. But the PCR test is still going to be able to pick up the infections in people beyond peak because it's much more sensitive. So even if there's a very low level of virus in the body, the PCR test is going to amplify that to be able until it's kind of a detectable level for the test.
Right. So a PCR test, for example, might be able to detect virus from day 3 to day 11, but maybe the antigen test from day 4 to day 10 or something like that. And it's a little bit on either side.
Something along that we think it's actually more, so for example, if there's a 3-day incubation period, that during day 3, the beginning of day 3, the PCR would be able to detect and the antigen test wouldn't, but by the end of day 3, they would both be able to detect it. So the window early on where PCR is more sensitive than the antigen test for viral load is a pretty narrow window. And the idea with the antigen test is it might be days 3 through 6 that an antigen test would come back positive, and then days 6 through much longer is when the PCR test would then be more sensitive. Okay. And so the idea here is during the peak, both tests are very sensitive in terms of detecting peak viral load. And that's also a really important time because that is when people are most contagious. So being contagious is correlated with the amount of the viral load, the amount of virus in the body. And so during the peak, most likely to be contagious, most easily detectable by the antigen tests.
And symptoms, is it fair to say symptoms tend to follow a few days after the ramp up of detectability? I mean, I've heard that contagiousness usually precedes symptoms by a few days, so that must.
So we still, we have a fair amount of data around it. We're still kind of understanding because the trends differ a little bit from person to person. But our best understanding is that contagiousness rises before symptoms kick in. And so we think about that as people being pre-symptomatic. So before their symptoms kick in, they are they're infected and contagious. And then there are also cases that are asymptomatic. They never ever develop symptoms, even though they're infectious, even though they're contagious during this period.
Yeah.
And so the latest studies I've seen, we think it's somewhere between 40 and 60% of all transmission is due to this kind of without symptoms period, either pre-symptomatic or asymptomatic. So it's about half of all transmission is driven during the period where there are no symptoms. And the key thing about that is that without so that's part of why we do social distancing and wear masks, because those are precautions we take regardless of whether somebody is contagious or not, even if we don't know. But the beauty about testing is that testing is a way to determine, is somebody contagious even if they don't have symptoms? And so the fact that so much transmission is driven by people who don't have symptoms really underscores the importance of testing, and not just testing once your symptoms show up, but the idea about people being tested on a regular basis, being tested frequently, being tested even if they don't have symptoms, in order to pick up cases that are contagious, even though they have no symptoms at all.
Yeah, so that's a good segue into just the concept of testing program. So I wanted to hear from you, what would your ideal testing program look like, and what would that deliver societally?
Okay, so the idea about having an ideal testing program, I always think about kind of what's achievable, what direction do we want to move in, how do we define kind of success, how do we define how much testing is enough testing. And the idea is that we want people to know their infection and contagiousness status at all times. That is the ideal. So everybody, no matter what, would know, am I contagious right now or not? And they need that information in order to make informed public health decisions about whether they are going to interact with their family members, interact with close friends, go to work, go to school, things like that. And so we want people to know their status at all times. And so there are multiple ways that we can achieve this, but the idea is that everybody should have easy access to testing. So the testing should be convenient, it should be free, It should be widespread, so a large proportion, ideally everybody in the population should get access to it. And they should be able to do it frequently. So the idea is not like I'm just going to get tested once every 6 months, but you can kind of get tested on a regular basis. And so we think about that as being the ideal. We can achieve that in a number of different ways. We can achieve that by having tests available at home so people can test themselves at home. We can achieve that by having what I call the Starbucks or the food truck model, where on every street corner there is somewhere where you can stop by and get a test, and it takes as much time as picking up a cup of coffee. We can have so those are kind of the most convenient. What we have now, we have kind of drive-up testing sites, we have walk-up testing sites, we have places where you can go, you can get tested through your doctor. There's a lot of options, but basically the idea is that the level of testing that Canada and the US are at right now is less than ideal. And so the idea is right now, most people in Canada and the US, if they want a test, they can get a test. It might take them half the day. Who knows when their test results are going to turn around, but that is not the ideal. The ideal is not like, oh, if I need a test, I can figure out how to get one. The idea is that the testing is so convenient that it's really easy to get and that we're willing to get it kind of more often. So the idea about having frequent testing is one way we can actually help control the virus. So if we're all just waiting until we engage in some activity we think is quite risky, or we have symptoms, or we know we've been exposed in order to test, well, that's going to be too late in a lot of the cases to avoid that kind of pre-symptomatic or asymptomatic spread that is a big driver of transmission. And so we want testing to be routine and easy. People get tested a lot, and it means we're going to be able to turn up cases, catch cases really early before they're able to spread widely. If we're looking for an example, so I do have one example though, with Slovakia. So a couple of weeks ago, Slovakia did a mass testing program. And so they tested a kind of huge proportion of their population one weekend and then the following weekend. And basically they were able to transmission in cases were kind of skyrocketing, and they were able to bring the number of cases down pretty significantly through this mass rapid antigen testing program. And so there is some evidence these mass testing programs really help to get cases down. Obviously, it's not just a one and done thing. Once you get cases down, if you don't continue testing, masking up, social distancing, your cases are going to rise again. But the idea that doing mass testing, they kind of demonstrated that it is possible to do it. And with the Slovakia case, it's also worth mentioning that they were using, I don't know exactly which antigen tests they were using because there are several on the market that have different levels of sensitivity and specificity. But the test that they were using, it is known for having a small number of false positives and false negatives. And as far as I know, Slovakia didn't do anything in particular to address the fact that it had false negatives and false positives. They just rolled it out. If you got a positive, it was a voluntary testing program. If you got a positive test, you were asked to quarantine for 10 days. If you got a negative test, you weren't necessarily given kind of free pass to do anything, but the idea that you were kind of you'd been tested, you got a negative test, and that was kind of a license to be a little bit less cautious. And yet the program was still very effective. So it basically tells us that false negatives and false positives can be a concern. And of course, we know there are ways that we can actually address them, but that also through a large mass testing program, that they are something kind of that they're part of the program overall. And that a few people, a small number of people will be affected by it, but the program itself can work very well to drive transmission down, even when there are some false positives and some false negatives.
I'd love to change directions a little bit and talk about how we can all use the data that comes out of testing programs on how many cases are we seeing, as well as the test positivity rate that people hear coming up now and again in the news. How can we use that as individuals to understand, we have a regional COVID dashboard and they report, how many new cases, and they report a test positivity rate. And I've also seen the test positivity rate used New York, used in Europe as part of their traffic light system. So can you talk a little bit about how these data can really inform what the situation is and help put the numbers and help us make sense of the numbers, case numbers?
Sure. So most people who aren't kind of public health experts are going to be looking at the case numbers when they're deciding kind of what the trends are, whether things are getting better, whether things are getting worse, what kind of precautions they think they want to be taking. And so case numbers are really, really important for kind of letting people know how serious the concerns are. We can also look at hospitalizations and deaths because, of course, there are a number of cases that don't lead to serious illness. And so we can look at hospitalizations and deaths. And the other important metric is the number of hospitalizations and also how overloaded the local intensive care units are. So when there's a large surge, the intensive care units get overwhelmed. And so it's actually much harder to get the type of care that somebody needs and can actually lead to far greater number of fatalities from COVID-19 than if the ICUs were not overloaded. So cases is what most people look at when they're trying to figure out kind of how serious is it. Also, you can use test positivity that gives you some information. The issue with test positivity is that you need to make sure you understand what it can and can't tell you. And there are several limitations about test positivity data.
Yeah, I actually had a personal experience where we got a letter last week so our schools here are open full time. And that there were actually 3 different schools in my area had exposure letters go out. And in my case, the exposure letter went out 8 days after the exposure. So, I mean, we've really doubled down here on contact tracing in BC, and it has delivered a lot for us. Like most of our cases are related to known outbreaks, and we have tons of people in quarantine at any given moment. But there are lots of examples where you find out, 5 days after you were exposed, and that's too late in a lot of cases. A lot of damage already can be done.
Exactly. I think with contact tracing, it's not always, so we think about, so there's the kind of index exposure and then a subsequent exposure and then the exposure beyond that. And so the letter 8 days in might be too late for you if you were directly exposed, but if you have potentially exposed other people, you would be able to kind of let them know. So the idea with contact tracing is that ideally we want to do it quickly, but oftentimes even some delayed contact tracing can still have an impact. And the beauty about testing is that a big component of contact tracing is that we want to identify people who have potential exposure in order to encourage them to get tested.
Yeah.
If everybody is getting tested every week, twice a week, whenever they've been exposed to other people, then those letters are a little bit less important because people have already been tested. And any cases that were onwardly transmitted are going to be identified already through testing. And so contact tracing is a little bit less important there.
Now, I'd actually be curious to get your perspective on why one of our policies exists. So here in BC, when they're pretty selective about who they send for testing. So if there's an exposure, even in your child's class, they're only going to contact the people who, maybe sat near that child. And they don't even suggest that the whole class. In general, it's not like a blanket policy that the whole class gets tested. And, there's various Facebook groups feeling like this is not enough. And they're not suggesting even that there's quarantining of siblings, for example, of that. So it's not an endless resource. And so I guess I'm just curious your thoughts on how do you, I don't know what the word is, manage that resource effectively.
I think it's a real balancing act because when there's a potential exposure, you want to kind of reduce onward transmission and you want to figure out who might be exposed, but also when there are limited testing resources and also that you don't maybe have the resources to test everybody in every class where there is some exposure. And also there's a risk when you kind of tell people very widely that they've potentially been exposed, there's going to be a lot more potentially unnecessary quarantine. And so it's really a balance between that. So basically what test positivity is, it's just simply of the number of tests that have been performed, how many came back positive. And so there are some slight differences in terms of how test positivity is calculated depending on the country or the province or the state. But that's kind of generally the idea about kind of how much of the testing we're doing is actually turning up positive cases. And so remember, test positivity is not a measure of prevalence, even though it is correlated with prevalence. So we want to be very careful about how we actually interpret the actual number of test positivity.
Yeah, I've seen some reporting about on New York where I thought, are they suggesting that 3% of people are positive? I mean, because New York has had this very clear 3% test positivity rate, and some of the language around that was suggesting that 3% of the population was positive. And I thought, Is that possible? I mean, if you're testing everyone, then your test positivity rate would reflect your prevalence, but if you're not, then it doesn't.
Exactly. So that 3% is not a prevalence, or the prevalence is much lower than that,
Yeah.
even in places that have very high surges. So we don't want to be looking at the actual number of test positivity and inferring anything about the prevalence level. So the
Mm-hmm.
way that I think about test positivity is so it can be used to calculate prevalence, but it's a complex function. We don't actually know what that function looks like. And
Mm-hmm.
so we don't want to think about translating test positivity directly into prevalence, but we can use test positivity in different ways. So one of the things about test positivity is that the higher test positivity is, the more likely there are more cases that have not been diagnosed in the population.
Mm-hmm.
And let me try to explain why that is. So when we think about self-selecting into testing, so most testing is people kind of decide they have symptoms, they're aware of some exposure, and they decide they need to go get a test. So most of our test is kind of based on people's need, desire, whether they think they need a test, and a lot of times that's directly related to whether they think they're likely to be positive. Somebody who has stayed home and not interacted with anybody is not going to really have any demand for a test because they know they haven't contracted COVID-19.
Mm-hmm.
Somebody who's been engaging in more risky behavior, who knows of someone in their circle they've had close contact with who is diagnosed with COVID-19 or who have COVID-19 symptoms, they're going to be much more concerned, but also much more likely to be positive. And so when test resources are limited, it's only the people that are most motivated to get a test who end up getting tested.
Mm-hmm.
So imagine those very long lines of cars we saw in the US and we still see sometimes. So if it's going to take an hour or 2 hours or 3 hours to get a test, somebody who doesn't think they're positive and probably isn't really sure if they actually really need the test is not going to wait in that very long line of cars. But people who like know that they've been exposed and need to figure out whether they need to self-isolate or have
Mm-hmm.
symptoms are going to be more willing to sit in that
Mm-hmm.
long line.
Mm-hmm.
So it means that when there's kind of shortage of testing resources, we're mostly going to be testing people who are very highly likely to be positive.
Mm-hmm.
And what that means is when there are shortages, a lot of people who are still contagious and maybe just don't have symptoms, or maybe have somebody in their circle who might have been exposed, but they're not certain about that, they're going to be a little bit less likely to get tested, and they may forego testing when there's a really big shortage. They'll put it off. So what that means when test positivity is high, it means most of our people being tested are those kind of most high risk people. And it
Mm-hmm.
means a lot of the medium risk and even some of the low risk people are not getting tested. And so that
Mm-hmm.
means there's a lot of people who have no symptoms of COVID-19, but are still contagious because we know you can be contagious even if you don't have symptoms. They're wandering, living their lives, hopefully wearing their mask, but we're not sure about
Mm-hmm.
that. And they're not self-isolating because they didn't think they needed a test. They didn't get a test, and they don't know that they're contagious. They don't know that they're positive.
Mm-hmm.
And so when we have really high test positivity rates, it means there's a lot of these undiagnosed cases circulating in the population. And that is a really big risk for transmission. People who don't
Mm-hmm.
think they're positive, yet a lot of them are.
Mm-hmm.
And so that's this guideline about test positivity. So when test positivity is high, you want to think about, well, what about all those people who are actually contagious but didn't get a test and have no idea they're contagious and are still meeting up with small groups of friends and maybe not
Mm-hmm.
wearing their mask properly and who knows what else,
Mm-hmm.
going to school, interacting with other people. So high test positivity correlates directly with a lot of undiagnosed cases in the population,
Mm-hmm.
which should be worrisome in terms of transmission.
Mm-hmm.
Also, when we have high test positivity and a lot of undiagnosed cases, it means the case numbers we're seeing in the news and in the data dashboard are not reflecting the total number of cases. So when we're
Yes.
having a surge in the US right now and the test positivity rates are very, very high, that tells us that the surge is literally just the tip of the iceberg. And there are
Mm-hmm.
many, many more cases that are contagious, that are spreading the virus, but they didn't get tested. They don't know that they're positive, and they are likely not to be self-isolating because they don't have the information they need to be able to self-isolate.
Mm-hmm. Yep, that makes a lot of sense, but it's good to hear the full story, the full picture, I guess, of how these two, the case numbers and the test positivity, tie together. Because I often, when I was making the decision whether or not to send my kids back to school when they're open, I was trying to wrap my head around what is the prevalence. One out of every X kids in the school has it. Well, I have the case numbers and I have the test positivity, and I know that higher test positivity means probably some under testing, but it's very hard to know. Are we talking a factor of 2 or are we talking a factor of 10?
And That's one thing that's really tricky to say. So I have a research study that used test positivity to back out prevalence. So it was on tuberculosis in South Africa, so totally different context. But the relationship between test positivity and prevalence is mediated by the type of selection, kind of who decides when to get tested and how. And so unless we have a really good understanding of who's getting tested and when and who isn't getting tested, we actually don't have the information we need to link test positivity directly to prevalence. And so I find test positivity is really good to think about trends. So if we see that cases are going up and test positivity is also going up, that's kind of a bad sign that things are getting worse. So in general, there are caveats to the test positivity data, but I find it useful for trends. So if it's going up, then things are probably getting worse. If it's coming down, okay, well, that means that like the transmission is slowing, but it hasn't stopped and we're probably still accumulating cases. The one kind of number that I've seen, and of course, this is like a rule of thumb average. It's based on US data. It's not so going to apply to BC or to other parts, but that when test positivity was at 20%, that it could mean that there were 5 times as many cases in the population as there are getting tested in the data.
Well, and so I think it's a very high number.
Right. So I think for the most part, high rates of test positivity imply that there are a lot more undiagnosed. Because you might think, oh, well, there's maybe twice as many, not 5 times as many. And so I think the important thing to remember is that we're aiming for very low test positivity. We want to keep it below 5%, below 3% if possible. And so when it gets up to like 15% or 20%, that's kind of a red alert range. It's not like, oh, it's just 20%. I'll worry when it gets to 80%. The idea is, I think, when test positivity is above, I mean, we should be worried when it's above 5% because that's kind of suggesting the epidemic is out of control. If things are up at 20%, that really is red alert. That's a really, really concerning number. And it's that same idea that when it's up at 15 or 20%, when test positivity is at 15 or 20%, it tells us that the cases we're seeing are just the tip of the iceberg. And we actually don't really know how big the rest of the iceberg is. And so we should be really concerned about that.
But at 5%, which is actually where we are in BC right now, and it's crept up a lot over the last just few weeks, that suggests some undertesting, but probably not in the 5-fold range. Or are there scenarios in which it could still be off by that much out of 5%?
No, I'm at the rate of 5%. It's not going to be 5-fold. It's going to be much lower than that. But we don't have good data on what those exact numbers mean, because it's kind of the prevalence is we don't see those cases. And so so we need a lot of data to be able to kind of infer the process through which cases in the population end up in the testing data. And we don't usually have good data on that. So one way to get around that is to do prevalence surveys. So we go and take a random sample of the population and test them for COVID. And then we have a sense. I'm doing some research using that type of data as well. We still have sample selection issues with them, but they're a little bit easier to address in the context of a survey. But if we have more data like that, then it makes it easier to kind of calculate, to figure out what that rate is that translates test positivity into prevalence. But the idea is that we use test positivity as one measure. We also want to think about actual number of cases as well. We can't just rely on test positivity because there are concerns about if the type of selection changes, so kind of who selects into getting tested, if that can change over time. And so that means the relationship between test positivity and prevalence actually does change over time. So it's not like we just need to know what it is at one point in time. It changes over time from one place to the next. So they're just it's a big undertaking to calculate that. But for most of our decision making, knowing that it's like that there are just a lot more cases out there is helpful. And I think we shouldn't be satisfied with having test positivity at 5%. The idea is test positivity should be at 0. If we can get test positivity to 0, that's having the pandemic completely under control, that there are kind of no tests. So the idea is not to say, well, let's keep it at 5. Let's say, well, what can we do to get it down to towards 0? And one of the ways to do that is actually just to scale up the amount of testing. It's actually not cheating on test positivity. That's exactly what you want to do. Test positivity is a measure of, are you doing enough testing? So if it's at 5% and you're worried that it's creeping up above 5%, the way to address that is to increase the amount of testing. make testing much more widely available. It will catch more cases sooner. It'll drive test positivity down. It'll slow transmission. It'll keep the virus under better control.
Yeah, we actually saw that here in BC when we sent kids back to school. We started testing kids like crazy because everyone got colds and they had to be tested in order to be able to attend class. And the test positivity rate in kids during September was something like less than 1%. Whereas I think the average test positivity rate was much higher. But kids were being screened like crazy because they had these confounding symptoms.
Exactly. And the good thing about that is that meant they were getting tested often enough, so you would be catching cases much sooner. And so the number of cases are also going to be, will be driven down in that population. So exactly. So the test positivity rate among kids might have been 5% before this increase in testing. And then with all the testing, you're able to get it down to 1%. And you can do the same thing with adults. And that is one possible policy to pursue. And I think that it is really effective because it allows schools to be back in session by keeping the rate of the virus down. It lets us, we benefit from having a little bit more freedom when we're able to use testing to keep the rates down. We're able to kind of ease up a little bit on the social distancing and scale up the testing and end up with a little bit more freedom so our kids are able to be back in school while also driving the number of cases down.
So I know you don't have a crystal ball, but I'm going to ask you anyways. What do you envision for the next 6 to 12 months? Will we have at home, will it start to be routine for people to test at home, or is that just too tricky from a regulatory perspective and unlikely to happen? And similarly, on site at some point, the idea of, at the daycare or at the school, they have, same day screening that includes, more than just a temperature check. Do you think there's a possibility that stuff will be rolled out routinely in different environments, large gatherings and so on?
I think that definitely in the future that will be more widespread. I mentioned the example of Slovakia that did a kind of mass testing program that seemed to have been quite effective as far as we can tell in terms of driving transmission down. So part of it is that as different parts of Canada and the US and different places experiment and try out these new innovative test methods, as well as innovative testing programs, that we'll have more evidence about kind of what works and what doesn't work so well. And we'll see those types of innovative testing programs diffuse a little bit more. So kind of, if somebody takes the initiative to be the first one and it's successful, then everyone kind of looks at that and learns from it. So I think that we'll definitely see more innovation in terms of testing. We're also seeing more innovation in terms of just the development of these diagnostic tests that will be more sensitive, that will be cheaper, so kind of bringing the cost down. And of course, the most important thing is just making sure that they are able to kind of manufacture enough tests to make some of these testing, kind of more widespread testing approaches more possible. I think the other thing to remember is that it looks like we have very likely to have safe and effective vaccines that are on the horizon. So of course, with those, there's still some additional approval processes that need to go through to kind of confirm the efficacy of the vaccines and the safety profile before they're kind of able to be given to the general population. But that is going to help as well. So when we think about controlling the virus and managing the pandemic, we have a whole toolbox in terms of social distancing, mask wearing, hand washing, testing, and then we'll soon also have a vaccine. And so the idea that kind of the more tools we have and the more investment we have, kind of the better vaccines we have and the better tests we have and the more tests we have, it's going to make it easier and easier to keep the virus under control. So I think 2021 is going to look a lot better than 2020 in terms of getting the virus under control.
So it sounds like you're recommending when testing is available, if it's ever offered to you, do it, because that will be a helpful thing for you and for society. But what about now when, there's debate about should the average asymptomatic test person doesn't technically qualify for testing go pretend they have a runny nose and go get tested? What do you do now while there are limited test resources?
I think the number one thing to do if there are limited test resources is to advocate among elected officials to increase resources for testing. Because without adequate testing, people are really stuck making pretty difficult decisions. So ideally, everybody could get precautionary tests whenever they wanted to. And then I think there was some debate here in the US around Thanksgiving about whether people who were planning on going to celebrate Thanksgiving with families should be getting a precautionary test ahead of time, or whether they should be saving those tests for people who have symptoms or people who are hospitalized.
Yeah.
And so the way I think about it is that from a public health perspective, we actually want the people that we want to get tested are the ones who are most likely to be in a super spreader situation. So if you are going to engage in a somewhat risky, large family gathering for Thanksgiving, that's actually somebody that we want you to get tested ahead of time if you're actually going to do that, to make sure that it doesn't end up turning into a super spreader event. Whereas the idea about that person not getting tested because they're worried about people with symptoms, well, the person with symptoms maybe already is self-isolating, and that test is not going to help us prevent any transmission. And so I think the idea is that testing really is good for preventing transmission. So we want people who are at risk of doing a lot of transmission to get access to those tests.
That makes sense. So we're pretty much out of time. Do you have any last words of wisdom to share, or misconceptions to kind of bust about testing and the way we can and should use it?
I am a big proponent of testing, and I kind of advocate to invest in testing, but there's a lot of people who kind of don't necessarily see the real value in testing, or think, well, it's really difficult to increase the amount of testing, so we're going to try to do more contact tracing and maybe do more lockdowns and maybe have more cases and more hospitalizations. But the idea with testing is that you can do a big push of investment in testing, increase the production of all the different types of tests. So PCR, you can increase, it's more difficult to increase the production of PCR, but for example, using antigen tests, so those rapid antigen tests, that those are able to be produced. There's several producers. I know there's at least 2 companies I'm aware of, the Canadian-based companies that produce those types of tests. And so kind of ramping up those types of tests as well, so that you're really investing not just in the PCR testing, but in other types of testing. And then thinking about strategizing around testing policy.